and thank you again for the introduction. So I think the next session is about SGLT2 inhibitors, and I think you'll learn a lot again, or at least you'll try to convey some more messages about SGLT2 inhibitors, but I'm sure you have heard some of the messages already. So let's start right at the beginning. I would like to briefly touch upon diabetes and heart failure, about what the guidelines of the ESC say about heart failure. I would also touch upon the EMPA-REG trial and dapagliflozin. So let's have a look. We recently published an editorial together with Stefan von Haehling and Gerd Hasenfuss from Göttingen, in which we discussed diabetes and heart failure, and that sugared words indeed prove bitter. Now, everybody thinks that diabetes is a big risk factor for developing heart failure, but I recently found a study looking at almost 8,000 patients, and they looked at the prevalence, or the incidence rather, of heart failure among patients with diabetes. And as you can see in the left panel, in the A panel, this is patients with HFrEF, and you can see that approximately 4% over 10 years in the diabetic patients developed HFrEF, but the proportion of patients developing HFpEF in this analysis was much bigger, almost reaching 50% in 10 years. Now, the guidelines do mention, of course, medications for diabetes and heart failure, and we had this discussion about the guidelines yesterday already. We're still dealing with the 2016 guideline, even though there was a clinical update published in May this year. But the guidelines do mention a number of anti-diabetics, and the one that is recommended, but we've also discussed this yesterday already, the one recommended is metformin still. However, there might be a change now with the publication of the diabetes guidelines recommending in patients of high cardiovascular risk to use SGLT2 inhibitors in the first place. So the only recommended therapy in patients with heart failure is metformin. There is also a recommendation now for SGLT2 inhibitors, and the glitazones also have a negative recommendation, so do not use them in patients with heart failure because they have been shown to increase the risk of myocardial infarction. They also increase water retention. There is not a lot of discussion about the gliptins, for example, the glucagon-like peptide-1 receptor agonists, or incretin mimetics, or insulin. All of them have been discussed to increase the risk of cardiovascular events, or if you take insulin, it is known to increase weight. There's also a significant sodium retention with insulin. So there's many safety concerns for the other drug classes. This is also true for sulfonylureas, but not so for the SGLT2 inhibitors, and I think we will receive more data in very due course. So looking at the famous tables in the guideline, you have seen that the glitazones, they have a class 3 recommendation, so do not use them in patients with heart failure, as they increase the risk of heart failure worsening and heart failure hospitalization. And metformin has a 2A recommendation. Metformin should be considered as a first-line treatment of glycemic control in patients with diabetes and heart failure. Now, the 2016 guideline already mentioned that recently empagliflozin, an inhibitor of sodium glucose cotransporter 2, reduced hospitalization for heart failure and mortality, but not myocardial infarction or stroke in patients with diabetes at high cardiovascular risk, some of whom had heart failure. This, of course, refers to the EMPA-REG outcome trial, but EMPA-REG outcome was not a heart failure trial, it was a diabetes trial in which patients at baseline had a bit of a tick box. Was there a history of heart failure, yes or no? So there was not a lot of information in the EMPA-REG trial about the history of heart failure. It was just a yes or a no. So the guideline also says that in the absence of other studies with drugs from this group, the results obtained with empagliflozin cannot be considered as a proof of a class effect. However, the situation is of course changing with the DAPA-HF trial recently published. Now, looking at the consensus recommendation of 2019, you have the statement here that in 2016 the guidelines indicated that empagliflozin should be considered in patients with type 2 diabetes and heart failure. But the 2019 clinical update now goes a bit further and says that the 2019 expert consensus was that canagliflozin and dapagliflozin should also be considered for patients with type 2 diabetes and established cardiovascular disease or at high risk of cardiovascular disease in order to prevent or delay the onset of heart failure and hospitalization for heart failure. Now, of course, you have seen the data of the EMPA-REG outcome trial. I would still like to touch briefly upon this. And the study population consisted of patients with diabetes. However, these patients also had a cardiovascular risk profile, and you can see that there were two different doses, empagliflozin 10 milligrams and 25 milligrams, which is kind of a bit of a disadvantage as compared to dapagliflozin, which only has one dose. And there was, of course, a placebo group, and each of these groups consisted of approximately 2,300 patients. So altogether more than 6,000 patients, and there was a pooled empagliflozin analysis. You can see that the mean age was around 63 years, and patients had baseline medication with beta blockers or angiotensin converting enzyme inhibitors. 80% were on an ACE inhibitor, 60% were on a beta blocker. So there was a lot of background medication already. Now, looking at the hospitalization rates for heart failure, and I think the investigators were really surprised when they saw this result, that empagliflozin, and it was kind of independent of the dose, reduced the hospitalization rates for heart failure. And this was very significant, and you can see that the Kaplan-Meier curves were already splitting rather early in the course of the follow-up. Now, looking at the time to first heart failure hospitalization or cardiovascular death, you can also see that there was a very significant reduction in the relative risk of being hospitalized for heart failure or of dying for cardiovascular reasons in the empagliflozin group. And again, the Kaplan-Meier curves were splitting very early, and you can see that even at 6 months already, there was a very strong trend for in favor of empagliflozin. Looking at the split between the two different doses of empagliflozin, you can also see that there is not much of a difference between the two doses of empagliflozin as compared to the placebo group in this analysis. The time to first hospitalization for any reason was also highly significant, and also again these Kaplan-Meier curves were splitting rather early. At 6 months there was also a very strong effect in favor of empagliflozin. Looking at the heart failure outcomes and all-cause hospitalization rates, you can see that heart failure hospitalization or cardiovascular death strongly significant with a hazard ratio of 0.66. This is the one taken from the Kaplan-Meier curve I've shown you just a minute ago. But again, hospitalization for or death from heart failure also strongly significant. Hospitalization for heart failure on its own, not as a combined endpoint, also highly significant in the EMPA-REG outcome trial. So since this was not a heart failure trial, but a trial of diabetic patients, there were some other attempts to understand the heart failure situation better, and one of these attempts was really to understand the time to the first dose of a loop diuretic, also in an attempt to understand better if these patients had developed heart failure. And again, this was highly significant with very early separating Kaplan-Meier curves in the analysis and over the course of the trial. Now, empagliflozin, and I'm involved in the EMPEROR trials that are currently ongoing. Empagliflozin is now being tested in prospective trials of empagliflozin versus placebo in the heart failure community. And as you can see, there is one trial looking at preserved ejection fraction, the Emperor preserved trial, and there's another one looking at patients with reduced ejection fraction, the Emperor reduced trial. And both are aiming to recruit more than 2,000 patients and looking at hospitalization and mortality in this group of patients. And you can see that the hypothesis behind this is to demonstrate superiority of empagliflozin versus placebo in patients with symptomatic chronic heart failure and preserved or reduced ejection fraction under stable treatment for heart failure symptoms. And the screening in the Emperor trial is like up to 3 weeks. The patients are then randomized in a 1-to-1 fashion, empagliflozin 10 milligrams versus placebo. You can see there's only one dose here in the Emperor trials, not two like in the Empiric outcome. And patients are then followed up until the end of the follow-up period. And this is effectively an event-driven trial. So dapagliflozin, of course, you have seen the data before. And I particularly like the sentence here from David Lehman, who says, if you're not paying for it through the health plan, you pay for it in the emergency department. I think there's a lot of truth in this sentence, and we need to adjust the medication of our patients, preferably on an ambulatory basis. Of course, you have seen the data from the DECLARE TIMI 58 trial, which was again a diabetes type 2 trial looking at 17,000 patients, 8,000 of whom were randomized into the active treatment arm with dapagliflozin. Patients were approximately 73 years at baseline, had a BMI of 32, and approximately 1/3 of the patients were female. There was one primary endpoint originally when the trial started, which was MACE, cardiovascular death, hospitalization for heart failure and ischemic stroke. However, when the EMPA-REG outcome trial was published, during the ongoing DECLARE TIMI 58 trial, the investigator decided to have a second primary endpoint, and the second primary endpoint was cardiovascular death or hospitalization for heart failure. And this finally kind of rocked this trial. As you can see, MACE was not significant for superiority. However, cardiovascular death or hospitalization for heart failure was highly significant. And again, there were Kaplan-Meier curves splitting not as early as in the EMPA-REG outcome trial, but this was the first heart failure endpoint really in such a trial. And again, the Kaplan-Meier curves were splitting at approximately 1 year. Now, the DAPA-HF trial was then conducted next, and the DAPA-HF trial included 4,700 patients, with half of the patients randomized into the active arm with dapagliflozin. You can see that patients were slightly younger, 66 years at inclusion. Again, only a rather small proportion of females, only 25% were females. Most of the patients were in New York Heart Class 2, like 70%, and New York Heart Class 3, there were approximately 30%, ejection fraction 31% at baseline. And the primary endpoint was a composite, like in most big heart failure trials, of worsening heart failure, which was defined as an urgent visit requiring IV treatment with a diuretic, or hospitalization for heart failure, and cardiovascular death. So again, this was a composite endpoint, and you can see the primary endpoint was highly significant, and again, soon splitting Kaplan-Meier curves after approximately 3 months this time. And you can see that this was published in 2019. And the interesting thing about the DAPA-HF trial is that even if you look at the different endpoints separately, each of them was significant. So if you take hospitalization for heart failure separately, this was highly significant. If you take death from cardiovascular causes, this was significant. And death from any cause was also significant. So with this, I would like to finish already. And of course, draw your attention to the mechanism of action, which is still only incompletely understood. Many studies are currently ongoing, looking, for example, at urine output after acute decompensation. So I'm sure we will better understand what is going on if this is really only a diuretic effect of the SGLT2 inhibitors? I do not think so. There might be pleiotropic effects that we do not understand as yet. Maybe there is a cardiorenal protection. Maybe there is a decrease in the uric acid or the oxidative stress. But all these studies are ongoing, and I'm eagerly awaiting what the results will be. So I've taken this picture when I was traveling to Cairo, like yesterday, and this was a very curious visitor during my trial, but it also during my flight. But it also kind of tells me we really have to look at the very broad horizon. Thank you very much.